in the last 6 there is not one morning in the last 60 years that I have gotten up and said, yippee, I can't wait to take care of myself. I just love this thing. I think at the end of the day, it's a major pain in the neck. And I don't think it takes rocket science to manage diabetes. I just think it takes a lot of courage and determination on a daily basis. It's repetitive, and I think after diagnosis, 2 weeks on, it gets a little boring. There's a lot of things that we have to do on a daily basis. I'm going to be talking today about how the relationship, what the relationship is between some of the things that we have to do, or all of the things that we have to do, either having type 1 or type 2 on a daily basis, and how that impacts us psychologically and emotionally. We have to monitor our blood sugars. We have to monitor food intake. We have to make insulin medication adjustments based on food and exercise. We have to exercise, deal with what happened before we're making our decisions, and accommodate to what's coming up front. Cope with not always getting it right. For me, this has been the most difficult aspect of living with diabetes, is doing my damn hardest to get it right. And for sometimes you just don't get it right, you know? There are times when I go to bed and my blood sugar is 92, and I wake up in the morning and it's 248. And I think to myself, you know, on the nights where I've had one of those bad lows and I've walked to the kitchen and I keep telling myself I'm only going to have 4 ounces of juice, but then I have 5 bowls of Captain Crunch, I know why my blood sugar would be 248 when I wake up. But there are mornings when I think to myself, what did I do? Dream of pizza? You know, so this is hard, just dealing with that kind of stuff. And I'll offer some tips that I've learned along the way and that I've worked with for working with patients that I've worked with over the years on how to come to terms with this. The thing about a chronic illness is that there is no fixing. And I think a lot of clinicians and people think that there's a fix. There's healing over time in terms of dealing with it, and how we look at it and how we approach it, and what our posture is from the beginning as we move through this journey of taking care of ourselves and trying not to get exhausted, or allowing ourselves to get exhausted, pick ourselves up and move on, and keep going, will determine what our blood sugars look like, and what our metabolic control looks like, and what our clinical outcomes will look like. So how we feel about it and what we do with those feelings has everything to do with A1C and medical condition in terms of preventing and retarding complications. Cope with not always getting it right. That is the biggest problem for me, as I said. Think about possible complications down the road, meaning that one of the things that sort of is difficult is the constantness of this. It's pervasive. As a matter of fact, I have a resentment against the United States government. I think they should give me $150,000 a year. I will stay home and take care of my diabetes and promise not to be a healthcare cost. The other thing about diabetes is that, so this is a full-time job. And not only is it a full-time job, but we don't get paid for it. We have to deal with pharmacies. We have to deal with medical device companies. We have to deal with refilling prescriptions. We have to deal with providers helping us refill these prescriptions. We have to deal with our own attitudes about how frustrating it gets spending 5 hours a month on calling these places to get our sensors, to get our insulin, to get our pen needles, to get our this. It's endless. And there are lots of opportunities here. I think getting diabetes, whether it's type 1 or type 2 or type 3, I don't know if any of you know what a type 3 is, but a type 3 is anyone unfortunate enough to live with a type 1 or a type 2. This is a funny thing. My hat goes off to them for living with us and suffering all the alarms. And all the times when they see that we're going low and we tell them, no, we're fine, until finally we admit that we're having a low and that they caught it before us. These are the things that I'm talking about in terms of like these things that we have to do have an impact on us on a daily basis. And the other thing that's difficult is for some of us, or a lot of us, dealing with the already manifested complications and moving on and not giving up and not feeling like the game is over, but redefining what the terms of the game are. And I believe that that's one of the most important aspects of living with diabetes. And I really, really, really think that it's not just a numbers game. It's not just about your blood sugars. It is about the concept and the experience, spiritual and psychological, a feeling of powerlessness, of the powerlessness of your partner, watching you have a low blood sugar and trying to make you feel better, of your sense of powerlessness when you get diagnosed with type 1 or type 2. Despite the fact that type 2 is a lifestyle disease, on some level, we had no say in whether or not, in what our genetic makeup is. So there's an aspect of powerlessness there. There's an aspect of fear, fear of complications, fear of judgment when we go to the doctor. What are they going to tell us? Fear of what my A1C is going to be, fear of low blood sugars, fear of not getting my sensors on time, fear of, it's endless. For each one of us, we have our own sort of little departments of and experiences of what these sort of major categories. But at the end of the day, it is not just a numbers game. It's about despair. It's about a partner's despair. It's about our despair. It's about feeling these things without giving up. My belief, and I think what is really important, my clinical experience, my own personal journey, and the journey that I've shared with all of the patients that I've worked with over the 40 or so years that I've worked in diabetes, has been this notion of we're all here for each other. We are fellow pilgrims, and the goal is not to give up. The journey doesn't have to be graceful. But I think getting diabetes is always an opportunity for spiritual growth. It's a major spiritual growth opportunity about acceptance and letting go. But to just follow through on some of the other feelings here that I wanted to sort of bring up and highlight, the anxiety of complications, the anxiety of, is the right dose, is the right thing, do I have the right supplies, am I most current in my treatment, this kind of stuff. A sense of failure when things don't work out. How do we deal with that? How do we sort of pick ourselves up when, like I just gave you the example of, I go to bed at 92, I wake up at 2:48, and like I said, do I dream of pizza? This kind of thing. Looking at your A1C and being disappointed, thinking that it was going to be better. The exhaustion that comes with living with diabetes and managing on a daily basis. Again, I want to reemphasize this. I don't think that it takes rocket science to manage diabetes. I do think it just takes a lot of courage and determination on a daily basis to suit up and show up. And this is my goal of working with patients, is to help them tap into their resources internally, psychologically, emotionally, socially, that will help them sustain themselves through doing well, collapsing, doing well, collapsing, doing well, collapsing. I schedule for myself, just to deal with some of the feelings of rage and disappointment and exhaustion, I schedule a diabetes depression day for myself every 3 months. I call my friends up, I tell them that I'm going to be depressed next Tuesday from 9 a.m. to 2 p.m. And I'd like them to call me and tell me how courageous and inspiring I am. And they go, but Joe, you're telling us to do this. I said, I know, if you want to stay on the A list, give me a call. And at the day of the call, at the day of the sick day, I'll call the depression day, I'll call my work and I'll say, listen, I can't come in. I'm having a diabetes depression day. That was the hardest thing for me to learn to be able to do, to admit that I was having a hard time. This thing is not easy. It's ongoing. It's chronic. And whether you have type 1 or type 2, They're both chronic illnesses that require a sustained effort over a long period of time. It would only be natural to fall apart every so often. That's what that diabetes depression game for me is. It sounds silly, but it really works, and it always puts a smile on my heart when I think about it and when I do it. And the fear of being judged is another sort of is another issue. The fear of us judging ourselves. I can't tell you how long it took me and how much work it took me to get over not self-flagellating myself over numbers that were not in target range, or that I was doing something that I knew I quote unquote should be doing, but just couldn't resist, like the 5 bowls of Captain Crunch instead of 4 ounces of orange juice, or 4 glucose tablets for low blood sugar in the middle of the night. This notion of being judged is a little bit difficult as well, and comes into play differently for different people. So that's another thing that we sort of have to deal with on an ongoing basis. For me, the most important aspect sort of click for me that occurred after many years of living with diabetes. I didn't get this immediately, but was this notion of acceptance and letting go. Acceptance doesn't mean resignation. As it says in the Serenity Prayer, which I have up here, God grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. I think this is a real lifesaver for people with diabetes. I can't tell you how many times during the day that I say these things. I'm now getting some steroid treatment for carpal tunnel syndrome, and I've already said the Serenity Prayer today about 4 or 5 times just around blood sugars, and getting frustrated with that and having to keep pace with the steroids because, as we know, it makes our blood sugars go out of whack. The other piece to this is really interesting as well. There's a thing about me. I have diabetes, but I live in the context of my family, in the context of my fiance, in the context of my friends. So I'm not doing this by myself. And I'll go to the last point on this slide to start with, which was my mistake and misunderstanding of what I was told at the Joslin Clinic 61 years ago. At that time, I was told, you'll be able to manage this by yourself. What I think they meant now is that together working with your doctor and your diabetes healthcare team, you'll be able to manage this, but that most of the driving will be in your hands. What I understood it to mean was that I don't need any help. I can do this by myself. And it took that attitude and that posture took a toll on me over the years in terms of thinking that I had to do it alone. It exacerbated all of the other feelings that I was talking about on this page here, on this slide here. And it took a couple of crashes, emotional ones and psychological ones, that led me to go to therapy and to get some help from the outside in terms of coming to terms with this. The first few months in therapy, when I was finally coming to terms with how difficult it was and being open and honest about this and facing the realities of living with this thing all the time, I cried a lot. And I can tell you that it was really great to break down and cry. It was like I was holding all of this pain and all of this frustration inside for so long. So when you come to meet with me as your diabetes educator, I would consider the session a success if I end up helping to make you cry before the end of it. That's always a little sort of sign for me that something's popped, and in a good way. And it's important that it happen and that the pressure doesn't build up over time. You can do it alone, no problem. You can score lots of points on it, but it's lonely and exhausting. Families and partners and spouses and friends make the journey easier. That requires some conversations with partners and family members and friends. How do we talk about it? I feel like my job as a diabetes educator is not only to help you learn how to adjust your insulin dose or titrate your medications, oral or injectables, but it's also to help you define the terms and parameters of the conversation that you have with yourself and with your family about how we're going to manage this thing. And it doesn't have to be it's certainly not a one size fits all, because we all bring different baggage to the event and different sort of life experiences. But it is important to recognize that our coping capacities and how we deal with things change over time based on the experience that we accumulate over time with living with this thing. Certain things are more I used to love having low blood sugars when I was younger, because that was an opportunity to have Snickers, to have Hershey chocolate, to have Captain Crunch, this kind of stuff. Now I'm finding it after having a lot of them over my entire lifetime, I'm sort of exhausted and I'm over with them. I don't enjoy them as much. That requires me to accommodate, but I have to be open to the feelings about this stuff in order to know what to do. The feelings are the trail markers for us to stay on on the trail and to sort of make it to the end of where we're getting to. For a lot of us, it's hard to let people in. And I would say that was certainly my experience at the beginning. I thought that I scored more points the better I danced, the more people said, it's so incredible how you take care of yourself. And it was hard for me to let somebody in and let other people in and to share the journey with us or with me. To this day, I still tell my fiance sometimes when she goes, "Are you all right?" And I know I'm starting to have a low blood sugar. My first response is, "I'm fine." It's as if I'm saying, I don't need any help. So the bottom line is this is where it becomes a family matter. When one of you has it and both or all of you live with it, whose diabetes is it? It's everybody's diabetes. And that's what we need to take responsibility for and be open to in terms of working with the entire family. For me, I'm always inviting all of the family members in, as many as possible, and as many are interested that want to work together. Because I feel like the home context and the home environment has so much of an impact on metabolic outcomes and management behavior. For families of kids and pediatrics, family emotional supportiveness is really important in terms of how the parents take care of each other and are they emotionally available to each other. The availability, is there flexibility with schedules amongst family members, how the family organizes itself, joint decision-making between the spouses, the value congruence. Do both parents think it's important to manage things tightly? Or do they think it's important that, does one parent think that you could do whatever you want and the cards will just fall where they are, and the other one's really intense about it? How do they work together? Communication patterns or messages about the rules about how we live with diabetes and how we manage diabetes, clear or confusing. And competence and effectiveness in terms of response to initial symptoms. These are things that we look at to base or to score a family on how well we think they're going to do. Studies have come out in the last year that we did at UC Davis in Sacramento with Dr. Nicole Glazer and Dr. Lindsay Lumba on Halbrecht on impact of family functioning. And what they showed in kids, at least, was that the most significant, statistically significant predictor of what a child's A1C would be a year after diagnosis was the mother's expectations and subjective sense of how supported she felt by the other family members as a wife, a woman, and a mother. That was the most statistically significant predictor of how a kid would do a year after diagnosis. There are no studies that talk about these things in couples, but based on my clinical experience for the last 30 years, 40 years, this is what I think of as in terms of what's important to look at about being able to make an assessment of people coming in about how they're going to, what their outcomes are going to look like. A style of interaction, how husband and wife or partners work with each other and how they play with each other. And what other life experiences have they had? The conversations that you'll have with me when you come in for the first time is, I'm getting to know you. There's a large social aspect of this. The reason I'm getting it is not to make snappy chatter repartee or social repartee. It's to get an idea about where you're coming from and what's important and how you have dealt with other traumas in your life, because that's going to be what, those are the sort of traits that you're going to bring with you to this game called diabetes. A clear definition of what each partner expects from treatment. This is really important, that both partners or all people in the family who are managing and living with this thing, adult children of adults who have diabetes who are no longer able to take care of themselves, what are their ideas of what constitutes the right way to go about this? And what constitutes good control, optimal management, you know, that kind of stuff. Emotional concerns of each partner. What is each partner worried about? Are you worried about, is a partner of someone with type 1 or type 2 worried about that they'll be able to dance at their children's wedding? Are they concerned about having all their limbs? Are they concerned about sexual availability in terms of some complications related to erectile dysfunction? The other thing that's important is, what has been this couple's and this patient's experience in handling difficult life situations and differences in the past? What are we bringing to the event that we can use or that we can maybe think about we'll need to change how these things go? Your emotional experiences of childhood have a lot to do with how you're going to deal with this experience of powerlessness and diabetes diagnosis when you get diagnosed. And then who wants what? What is the value congruence or dissonance between the partners or among the family members in the family? These are important issues that one needs to bring up. In terms of sussing out the individual experience, emotional and psychological experiences of each family member, this stuff is as important as learning how to adjust your insulin dose, or how to manage hypoglycemia, or how to titrate your doses if you're having a surgical procedure. The interventions that I use when I'm working with adults with type 1 or type 2 is an expanded definition of the patient. I can't do this as a clinician all by myself. I need to engage and want to engage and realize the value of engaging all of the significant others in your life in terms of leaning a shoulder into this chore of living with and managing diabetes effectively. The emotional responses, I was saying, of spouses is critical to the development of the treatment plan. I'm working to help the couple identify and work on mutually agreeable goals. Would you like for her to be involved? Would you like for him not to be involved? Would you like to tell her that this is none of your business, I got this, I'm managing it by myself? All of these sort of things that go on in families that we are sort of intimately involved with on a daily basis without a chronic illness tend to get highlighted and exacerbated in either a positive or a negative way. One of the most positive aspects of this is that you learn more about intimacy and boundaries and the capacity to lean on somebody else and not have to do it by yourself. One of the negative aspects of not working through some of these and talking about some of these emotional and psychological issues that are more systemic as opposed to an individual feeling or thought or sort of pattern is he's always nagging me. I feel like she doesn't understand what I need from her to be able to manage this thing, those kinds of things. And like I said just a second ago, it's important to focus, and I always focus on issues of intimacy, trust, and strength. How is this managed? How is this information about making yourself vulnerable to another person going to play out? And the other piece that's really important here for me as an educator is I am happy to help you learn how to do this, but I will not work harder at taking care of you than you. My goal is to teach you as much as possible about leaning on this thing and doing it by yourself. That means a lot of work up front, a lot of phone calls, a lot of conversations, a lot of sort of back and forths about how to manage this thing. But my goal is to put you in the driver's seat. I don't know if any of you were on the webinar today. Remember that advertisement, the television commercial of the guy who was the Maytag repairman. The idea of the commercial was that the guy was sitting there alone with a sad sack sort of dog. Nobody was calling him. That's because the equipment was so great that nobody needed to call him. That's what I like to set it up as, that I'll be that Maytag repairman. I'll work with you at first to really put your plan together and to get you going. But then at the end of the day, I'm there sort of as a supervisory ongoing consultant. I'm not there to do this for you. I can't tell you how many patients come into my office. They've had an insulin pump for 3 years and they do not know how to change basal rates. I'm flabbergasted that they don't know where to go to look for insulin to carb ratio or insulin sensitivity factor. These are the things that I think each patient, whether you're type 1 or type 2, needs to learn how to do, how to carb count, how to make adjustments that don't require a physician or an educator to do for you. How to work on basal rates, how to use pumps effectively, how to use pens, how to use all of your tools effectively. My goal is to make you as expert as possible so that I have less work down the road. So it's a marathon, not a 50-yard dash. And that's what I think we're talking about. That's my attitude about this. Your coping strategies is for the long term, not for a short-term thing. Failure is part of success. What it means is if you're failing, it means that you are doing something and that there's something to be learned out of each little failure that we experience, whether it's in the emotional area or whether it's in the diabetes medical management area. Failure is just a built-in part of success. And what we have to learn to do is to embrace it without judgment and to move forward with it and to learn from it. Diabetes management requires a lot of trial and error. Much of living with diabetes has to do with seeing what works and what doesn't. This means that a lot of this is on our. Diabetes is a unique disease in the sense that there's not any other disease that I know of that requires, where the clinical outcomes are so dependent on patient behavior, on the person who has the disease's behavior. This is so important. And given that, and given how important we know and what an important role feelings and psychology and emotions play in how we behave and what we do, it is so important to have conversations. It doesn't have to be all the time, but it has to be open, frank, and honest conversations about how I'm feeling, what's going on. It is not a failure to say I'm sick and tired of this. It's actually quite a success to be able to be that vulnerable, to admit it, so that you leave that there and you have a lighter load moving on down the road. Elliot Jocelyn, who was one of the first physicians in the country to administer insulin in 1922, clinic in Boston, which I think a lot of people know about, said the patient that knows the most does the best. And that's it. But I just want to add there that it's not only that knows the most, but that is most vulnerable and most accessible to how they're feeling and deals with those feelings in an eyes wide open sort of perspective. You need to be in the driver's seat. And it's the only way to deal with the larger existential issues that we're talking about. Powerful, powerless, fear, despair, anger, rage, frustration. All of these things we need to do with eyes wide open. These are not bad things to have. These are things that are just part and parcel of what constitutes us living with our disease. I guess that's it. May the force be with you. I don't know if any of you know, but the force for Yoda, sometimes you can't see it, but on this picture you can, is based in his insulin pump, in addition to his Jedi Jedi sword. So I'm open for any questions or issues or things that people wanted to ask about.
Yeah, thank you so much for sharing, Joe. We do have somebody's question comment. They really want to hear also about maybe some positive attitudes about dealing with diabetes as well, and kind of like how you turn around and sort of, think about diabetes in that way. And then anyone else can type in questions and I'll continue to ask Joe.
In a positive way, could you ask them a little bit more about what they mean?
Yes, I can definitely do that. Or whoever typed that, it was an anonymous attendee. So whoever did type that, maybe if you could type more into the Q&A.
I'll take a stab at it. I'll just say that some of the positive things that about living with diabetes are that we have learned how to build up a tremendous amount of resilience, and we can apply that to other areas in our life that we know that that things take a lot of work and that you have to put in. So building up resilience is one positive aspect of living with diabetes. The acceptance is accepting things as they are and not as so much as how we'd like them to be, trying to get there, but not letting go of the dream, staying committed, strength and character. I think that I would have been a different person, and a lot of us would have been different people had we not had the strength and character to sort of come to terms with this thing and live with it on a daily basis. So I think those things are pretty positive in terms of they're muscles that I think get developed as we live with diabetes over time. I think that if we feel like we don't have enough of those, then there are places to go, as I said, family, healthcare professionals, mental health professionals, to help us learn how to look at ourselves in a more positive way that says, I got this. You know, the thing that I love about, I work out on my Peloton from time to time, and the guy who's my trainer on one of the New Zealand rides always says, as we're moving into a really hard climb, he goes, you got this. And I would say that, I say that to myself all the time, you got this. And I think that that stems from some of those positive traits that we have about resilience, strength, perseverance, courage, determination on a daily basis. Hope that helps.
Yeah, I think so. Somebody also asked if you could remove your screen sharing because they want to see you in your full face.
Yes, of course I can do that. Yes, there we are. That's
okay.
me.
Great. And then somebody else was asking, how can you overcome an unsupportive or apathetic family member or partner?
You smack him in the head. I'm kidding. Did you guys, I was joking. You hit him over the head with a hammer or something. How do you get a non-supportive family member? You can tell them something like this. This works a lot of times. You can say, listen, I just want to share with you how important it is for me to know that you understand what it means for me to live with diabetes on a daily basis. And I want you to know that there's a really deep part of me that needs and wants your help, but I can't force you to do it. But I need you to know why this is important to me. And then I would advise the person to say, why is it important to them for this person to understand? It's hard for me. So for instance, when we eat and you tend to offer me things that you know are going to raise my blood sugar ridiculously, I feel like you're setting a trap for me in that way. It doesn't feel supportive. It feels unsupportive. Or when you just tell me to suck it up and to deal with my low blood sugar on my own because you already have enough things to do, that hurts my feelings. And giving you for instances, but the most important piece in a general kind of way is to say, listen, I just need you to know, and I want to share with you why it's important for how important it is for me to have you help me do this thing. Now, at the end of the day, acceptance comes in when some people just won't do it. And then you have to come to terms with, how are you going to do this by yourself? And what other sources of support are you going to get? We can't make other people do things that they don't want to do, or that they're not constitutionally capable of doing. It doesn't mean that they're bad. It just means that they're not available.
Yeah, thank you for sharing that and the verbiage too. You have another question. What would you recommend to me in helping my mother who is resistant to taking insulin and not consistent with her treatment?
I would say, listen, Mom, I love you. And I can't force you to do anything, but I just want you to know how painful it is for me to watch you not take care of yourself. I have so many resources that I would like to help you with, and you're an adult. And I'm tired of trying to nag you or make you feel like I'm trying to nag you or to do better and this kind of stuff. I am here for you if you want. I will deal with how difficult it is for me to watch you not take care of yourself. But I need you to know that I will not bother you anymore, but I will let you know that I'm here. And because I love you and because I know you love me and you care about me, I need you to know how I feel about this. We'll leave it at that.
Thank you. Another question, what are, in parentheses, small victories that you celebrate when it comes to diabetes?
Ooh, managing this steroid shot that I just got 2 days ago. I feel like I'm a freaking genius if my number is 122. I'm like giving myself a lot of attaboys, 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 attaboys. The other night, after like several hours after I got the shot, I needed to take 30 units of fast-acting insulin over the course of 2 hours. And I will share with you that I was nervous about that, but I've done this before because I've had injections of cortisone in my knee. And I know that the way the cortisone goes is very pulsatile when it first gets in there, and you just have to kick its butt. And so I felt really, really incredible. Another one that I felt really incredible about was a triathlon that I did, an aquathon that I did, where I ended up with my blood sugar starting out at 102, and I ended up with my blood sugar at 87. Another one was a 50-mile ride with my brother, who also has type 1. By the way, it was an interesting experience with that. Well, I'll talk about that at the next webinar. But those are some of the things. The physical accomplishments of traveling around the world, of living in the desert with the Bedouin for 6 months while I did my postgraduate work, and eating and having to check my blood sugar and urine sugar to make sure that I was managing the Spartan kind of a diet, which was a lot of rice and a lot of sugar tea, but still managing to stay in control. Coming to terms with some of the complications that I have. I have gastroparesis as a result of this. My kidneys are starting to decline in terms of functioning, and managing to not get off the rails on this, but to sort of stay the course, fall apart internally, suit up and show up, take time off from work if I need to. But I think out of all the things that I'm most proud about, that would probably be one of at the top of the list, of dealing with the emotional terror that comes with that, of having gone through the terror of major laser therapy 30 years ago, where I had retinal hemorrhages in both eyes related to my over partying when I was at college age, and not taking care of my diabetes, and coming to terms with that. Not living in regret, not shutting the door on the past, but acknowledging my role in it and coming to terms with it. Those are the things that I feel most proud about.
Thank you so much for sharing that. Definitely. There's another question, just asking, is there a glucose goal of 100 or 90 or some other number first thing in the morning or after a meal? So it's looking like this person's asking about blood sugar goals and recommendations.
Yeah. In a silly way, I would say I always love getting 100. Every time I get 100 on my meter or my sensor, I think I'm a genius. And it's only because that was the score that we got in school, tests, 100 or not or fail or this kind of thing. But I'm shooting for around, I'm okay with like, if I'm not feeling hypoglycemic, because look, everybody knows that diabetes is easy to manage if you don't eat. You know what I mean? So when I go to sleep and I'm on my insulin pump and my basal rates are set and I'm on control like you, it's like, I know I'm going to wake up in the morning, okay, again and again and again, you know? And so I'm okay waking up at around 75, 80, 95, 100, 105, 110. Once it starts getting over 110, I start to think, do I need to make a change to the basal rate as a fasting blood sugar? You know? But 100 is my favorite number.
Great. I think that is all the questions, but lots of great questions. I feel like people had lots of really great things, and yeah, we really appreciate your expertise in living with type 1 diabetes, and then also just your honesty and openness to share and to give some new perspectives. I think this is so amazing. So really appreciate it.
It was a pleasure. It's like the St. Francis prayer, you know, it is in giving that we receive, it is in healing that we are healed. And I think that's why I became a diabetes nurse. There's a lot of it in that respect. Yeah. So thank you for the opportunity. It has been an honor and a privilege. Thank you.
Yeah, thank you so much. And thank you, everyone. And people are chatting in and saying that it was really helpful. So yeah, thank you so much. And this recording will be up on the website in a couple days. And so if you want to go back and refresh your memory, feel free. And thank you all. We'll see you next month. Okay, bye.